Good morning. Thank you, Kelly. Appreciate that. Let me get this. So yes, I took this opportunity as hopefully as a heavy lift, or also hopefully as an inspiration. I obviously live in a glass half 7/8 full in pancreatic cancer, and it's been a up and down journey from this aspect. But I'm hoping that this talk will kind of give you some at least some enthusiasm or optimism where we are with pancreatic cancer, and then also as a motivation of where we can hopefully dive into and get some of the benefits that we've seen in other immunologically active cancers, such as lung and melanoma and things of that type.
You minimize that Zoom thing.
Yeah, let me see. Yeah. So I'm an educational consultant for Intradynamics, which is one of the manufacturers of the devices I'm going to talk about with this irreversible electroporation, and then PI of the recently approved sort of direct trial, but I will not be touching on that today. Objectives for, at least for the students and the residents, is a short introduction on how we manage pancreatic cancer. What are the challenges that we see with it? What are the things that we have learned in regards to its underlying treatment and underlying molecular testing and potential treatment? Understand sort of the immunology and the immuno-oncology landscape, where it is, and ultimately where it's been flagging or failing in pancreatic cancer, and then where we have seen some significant benefits, collaborations, and improvements in the use of immuno-oncology using 3 different types of treatment, both systemically via IV, intratumorally, and then as well as orally. So the current biology of pancreatic cancer is it's not obviously going away. With nearly 60,000 cases diagnosed in 2020, it is over now 60,000 in 2023. The challenge is, or the pessimism is a very small percentage of patients will present with stage 1 or stage 2 disease, which are technically and biologically resectable. Really where my focus has been over the last 12 to 15 years has really been in this subset, in the stage 3, a larger percentage of patients. And the only reason for that is because we've seen over the last 15 years that there are a subset of patients with stage 3 pancreatic adenocarcinoma who stay stage 3, meaning they stay localized. It is a local problem to where potentially surgery, ablation, systemic therapies could play a role in extending that overall survival. I'm not going to focus in stage 4 disease. Really, my main focus is going to be in locally advanced or stage 3 or borderline resectable stage 2Bs, and I'll give you what those definitions are. Again, glass is 7/8 full. It's hugely optimistic to be enthused about pancreatic cancer when we finally get to a double digit for 5-year survival rate. That's obviously a little bit ominous in the fact that we've been so low for so long, but we are making very slow incremental improvements in the management of this disease. Now for the students and some of the residents, why is pancreatic cancer so lethal? Main reason for that is that there is absolutely no screening tool available. More importantly, there is no screening tool that has even been recommended by the U.S. Preventative Task Force. The main reason for that is that for something to be recommended, 1 out of every 100 to 150 patients need to benefit from that. Currently, only 1 out of 8,000 Americans would benefit from either MRI screening, CT screening of some type. And so because of that, it has never been recommended. And so we are still well behind the stage when patients are diagnosed, since nearly 80% of patients are diagnosed at a higher stage. The other part of this is also, which you will hear about a lot, is the underlying microenvironment and biology of the tumor. It is a very fibrotic type of tumor with a number of heterogeneous mutations. So there's not just a true 1 or 2 targetable lesions that we've seen with this cancer. Now, from a staging standpoint, again, stage 1, early stage, stage 2, again, both resectable. T3s is where you start to get into what we would call a borderline resectable or stage 2B because of the involvement or partial involvement of the SMV. T4 lesions fall under stage 3, are locally advanced, such that there's greater than 180-degree involvement of the SMA or SMV, or there are N2, or there are multiple lymph nodes involved, which will make stage 3. Clearly, stage 4, as you can see here, is more metastatic disease. From that staging, from the AJCC to then what is the clinical staging, which is a key part of this. Pancreatic cancer is one of the few malignancies that we involve a significant amount of systemic chemotherapy decisions, surgery decisions, purely based on imaging. It is a clinical stage diagnosis. And so the quality of the imaging will ultimately dictate the quality of the staging, which will then ultimately dictate the quality of the treatment. Time doesn't allow me to go into that, but just so you can understand, we're predominantly going to be talking about stage 3s with just T4, not N2, and then stage 2Bs, which are the ones that are borderline resectable because of vascular involvement. Now, ultimately, what are the risk factors? Obviously, all of them are fairly low penetrance. Advancing age, male, Black, these are all established risk factors, but not ones that are screenable or not ones that potentially can be early diagnosable. Ultimately, the only thing that has seen some improvement in the last 5 years, and to which we are trying to educate the primary care physicians, is the etiology of new onset diabetes over the age of 50. Clearly, a diagnosis of new onset diabetes over the age of 50 is a marker of pancreatic dysfunction, and that does have a fairly high rate of diagnosing a pancreatic disease and potentially pancreatic malignancy. We do know that obviously patients with first-degree relatives are clearly at a higher risk of developing pancreatic cancer, but patients with new onset diabetes, about 1 in 100 of those will develop pancreatic cancer in 3 years of that onset of diabetes. Starting to make that awareness within the primary care physicians is continue to be an ongoing battle, and that those patients potentially need to be screened just like you would screen other patients with new symptoms over the age of 50. Now, how do we decide on treatment? What happens in the office? What happens in the clinic? How do we as surgical oncologists decide on surgical resectability? How do medical oncologists decide on treatment aspects? It is a multifactorial. Clearly, most of them are definitely going to be related on patients' physiologic age, their underlying fitness and activity. Chronological age does play a role in a lot of decision-making in regards to systemic chemotherapy, underlying both comorbid conditions or modified comorbid conditions, such as patients are malnourished because they've not been educated. Those potentially are modifiable and they can be improved. If patient is weak because they don't really have understanding of physical therapy and occupational therapy, those can be modified or improved. If someone is jaundiced, comes in with a bilirubin of 15, 20, and is highly yellow, that can be modified with obviously an ERCP and a stent. So kind of understanding what are the risk factors that can be modified and improved, and what are the risk factors that are permanent. High-risk cardiac disease, high-risk pulmonary disease, high-risk kidney disease. These are all two things that may not be modifiable and are chronic, and ultimately may make the decision about the aggressiveness of treatment and the ultimately effectiveness of treatment. Now, it would be remiss if I didn't at least talk about some of the molecular subtyping and genetics within pancreatic cancer. There are definitely known targets that if you have this type of defect within your malignancy, or you are a BRCA positive tumor, there are significant benefits. The challenge with that, though, is that they are exceedingly rare. This is a older publication, 2017, to which nearly 300 patients underwent genetic profiling of their tissue following resection, and you can see that only 4% of them had any type of level 3B marker that was actionable, and 5.5% had any type of level 2B. 68%, the ones that were able to be genotyped and evaluated, had no actionable marker, which is where obviously some of either pessimism or lack of optimism or ultimately sort of nihilism occurs. This has also been occurred within the immuno-oncology arena. There was huge amount, obviously, and there continues to be a huge amount of practice-changing benefits that we've seen with immuno-oncology drugs, especially melanoma, lung, kidney, bladder, and even colorectal. However, pancreatic cancer has not been one of them. There have been numerous negative articles for that. And it is because of that, just to give you as a comparison, melanoma, nearly 50% of patients will respond to single agent or double agent immunotherapies quite well and for a long time, 4 or 5+ years. And in comparison, pancreatic cancer is less than 1%. So it still remains a significant challenge as to how we can enhance that type of action. Now, BRCA1 and BRCA2 mutations are definitely highly favorable mutations. And so it goes without saying, anyone who is diagnosed with a pancreatic adenocarcinoma should undergo next generation sequencing or molecular subtyping. There are definitely a very small percentage, but if you do win that lottery and you are in that approximate 6 to 7% of patients, you are highly likely to respond to platinum-based therapies far better. And there are some patients who will respond to simple FOLFOX-based chemotherapy for extended period of time, both with downsizing of their primary tumor and even downsizing of their underlying metastasis. There are also new PARP inhibitors or oral therapies that have also been found to be a benefit. Low toxicity, easy tolerance. And so the benefits of this type of genotyping is but small, but it is potentially highly effective in a certain subset of patients. Currently, here's this treatment sequence that we see with patients with pancreatic adenocarcinoma. Most of us in this room would agree that it starts with about stage 2Bs and on, such that first-line therapies are either going to be a doublet of a gemcitabine and a Abraxane or nab-paclitaxel, or modified FOLFIRINOX. That is predominantly decided on about age, comorbidities, underlying modifiable risk factors, and also just goals of the patient. Sure, some patients over the age of 80 may agree to only do single agent therapy because they're just looking for potentially double-digit months as a potential benefit. Patients who are in their mid-50s and diagnosed with disease may go more aggressive and will obviously want to use a modified FOLFIRINOX-based treatment with the response rates of 30 to 35%, because it potentially enhances their chances if they're localized to going on to surgery, or if they have metastatic disease for potential disease control. Now, what's the meat of this talk? And the meat of this talk is predominantly that pancreatic cancer has been exceedingly resistant to all immuno-oncology therapies that I've mentioned. And the main reason for that is that pancreatic adenocarcinoma, by definition, is a cold tumor. It is not immunogenic. And the absolute two most common reasons for that is it has a very low mutational burden, as I mentioned before, from a PD-1 expression or even an MMR expression. The other part is the inaccessible tumor microenvironment. For some of you all who have not seen pancreatic cancers in the operating room, essentially a pancreatic cancer is rock hard. All right, it is essentially a piece of cement that has microscopic cells throughout that cement. That cement is usually hypovascular, meaning it is not perfused by vessels, which means it is very hard to get any type of high dose systemic therapy directly to the tumor to elicit that type of response. In addition to that, because it is a highly immunosuppressive type of environment, it has been very difficult to see any type of response rates from either singlets or doublets from an immuno-oncology standpoint. This aspect is predominantly because of there is really essentially very little type of induction of antigen release. When a patient has a pancreatic cancer, there are usually minimal symptoms, and more importantly, there is minimum type of antigen release that occurs from that. And so even though we have potential actionable targets, as you can see here and outlined here, for the treatment of these types of process, the biggest problem is delivery of the therapy to the tumor, and then more importantly, overcoming a very highly aggressive immunosuppressive environment within that area. As an aspect of that, it's really where this is, I believe, is sort of the rate limiting factor where we as surgeons and we as treating physicians could play a role. As you can see here, there are well-established anti-CTLA-4 as well as anti-PD-1 and anti-PD-L1 that are very actionable in certain areas of the cell cycle. However, if you can't overcome this area of immunosuppression, ultimately we may never get any type of benefit. And so it was this idea about 7, 8 years ago that began for me to begin to think about that. And the think about that is what, in regards to that, is what type of tumor disruptive type of therapy could occur in this area? Meaning, did we have a potential treatment that ultimately could induce that type of tumor disruption to overcome this type of immunosuppressive effect and cause either a hopeful durable release of cancer cell antigens or at least a transient release of cancer cell antigens? And this is where that concept of using irreversible electroporation began to formulate within our lab. The other piece of this is also what we've learned around immuno-oncology and immunotherapy is that there are potentially a sweet spot in certain cancers as to when immunotherapy should be elicited. This is just a hypothetical curve demonstrating that obviously there is not an overall optimal window where immunotherapy can be initiated. Ultimately, what we're trying to do is identify an inflamed state. We're trying to identify when that tumor may be transiently hot so that when we release and induce that type of immuno-oncology effect, we'll get a greater effect from that. And so that's really what we had to learn starting in 2015 in regards to the use of IRE, is where was that potential sweet spot? Now, there have been significant amount of clinical studies. This list here is just the most recent from 2020 to 2019, and this is really only just 6 of them. There have been a total of actually 50 studies in pancreatic cancer to which immuno-oncology and pharma have utilized doublets and triplets and all types of things, all of which have had almost the exact same type of progression-free survival and minimal overall survival benefit. And so ultimately, it's one of the reasons why most of all of the large immuno-oncology pharma companies have very little interest in pancreatic cancer. Now, the area where I wanted to focus, where I felt surgeons could play a role, again, is in that immunosuppressive tumor microenvironment. Could we overcome that? Could we enhance that in that area? And so that's what I was mentioning before, is that immunosuppression and where ablation potentially plays a role. And these are areas of research that we have focused on both within the pancreas as well as within the liver in our lab, looking at both IRE, irreversible electroporation, and then also looking at thermal ablations as well as radiation as all potential areas to cause that type of permanent or transient tumor disruptive aspects, which could lead to that type of activity. Now, we've had a number of studies, and Connor O'Neill, one of our former fellows here, who is now an assistant professor of surgery in the Division of Surgical Oncology, University of Vermont, helped write up our first evaluation of that. And I'll go through these studies, but there have been other recent studies looking at this type of concept of both IRE with various types of immuno-oncology therapies, as well as using high-dose radiation potentially as an actionable area. And I'll walk you through that. Now, ultimately, what we have identified is that ablative therapy, specifically in these cases, irreversible electroporation, has ability to sensitize that tumor microenvironment and potentially make immuno-oncology agents potentially more therapeutic. The biggest issue for that is, when is that timing? We know that if we can initiate that type of immuno-oncology dosing right after the priming phase, and in that between that priming and effector phase, we potentially are going to get more actionable response and potentially more clinical benefit for that. The problem is no one knew when to do it. And ultimately, meaning, should we do immunotherapy prior to surgery or prior to an ablation therapy, or should we do it after? What is the potential sweet area or sweet spot when that dosing should occur? More importantly, the aspect of that, is what is electroporation? Many of the students and maybe residents don't know, but ultimately it's been around for years. It's been used in the basic science lab for nearly 20 to 30 years to either load DNA proteins, small molecules, large molecules. If you've ever been in the lab and you've done electroporation and you over-electrocute the cells die. So you then lose potentially 2, 3, 4 weeks of work. And so it's that concept that we're trying to elicit. We're trying to elicit that type of therapeutic voltage change of at least 700 volts between a positive and negative charge to elicit that type of intact cell, which then transiently breaks up the cell membrane. Calcium will enter the cell, sodium will leave the cell, and then you will get a slow apoptotic effect over approximately 8 to 10 weeks period of time where that cell death will occur. And so it is right in this area that we believe that there potentially could be a immunomodulation or window of effectiveness of treatment. The procedure is commonly here done openly through a midline incision, and many of our residents have helped me with this, to where we are bracketing the tumor, we are bracketing the vital structures, this being the SMB and SMA, and eliciting that type of electroporation in a therapeutic attempt to cover the entire tumor and lead to that type of treatment. It is this type of immune response that we were really interested in 2015 and 16. And so it's because of that that we initiated our first sort of clinical trial, and it really was just a serum evaluation trial. We wanted to find out what was this type of IRE effect predominantly on T regulatory cells, and whether there was that type of transient modulation effect. And so what we ended up doing is basically looking at patients who were undergoing IRE in an in situ without resection, and then comparing that to patients who underwent pancreatectomy alone. And these were 11 patients who went IRE alone, 4 control patients who underwent pancreatectomy, and then we did serologic evaluations at pre-op, day 1, 3, 5, day 7, or till discharge, and then at day 14 and day 30 to evaluate that type of T regulatory type of effect. And what we ultimately found, interestingly enough, is really between day 3 and day 5, we saw in the IRE patients here in red a significant amount of downregulation of T regulatory cells. And it was really between that day 3 to day 5 post-op, when the patients are still inpatient, that there was that potential transient, what we felt, window of treatment. And so it is with this window of treatment that we were able to get one of the immuno-oncology companies to okay us to be able to use the immunotherapy, that being nivolumab, in this type of perioperative period. Now, this was a phase 1B study, and so it was predominantly evaluate just the safety and tolerance of giving immunotherapy. It had never been done before where patients were operated on, and then post-op day 3 to 5, when they're still inpatient, to actually get their first dose of immunotherapy. It took a great deal of negotiation and discussion with Bristol Myers because they were very concerned that we needed to wait 6 to 8 weeks. The reason why I was concerned about that is I felt that that immunomodulation, that upregulation, that sweet spot effect would have mitigated, and essentially we would just be giving Nivo to a cold tumor. And so we initiated this with a small study, just 10 patients, to where we did IRE, and then as stated before, at day 3 to 5, they were then given a single therapeutic dose of nivolumab every 2 weeks for a total of 4 doses. Just a safety study. This was not a long-term. And then after that, patients could then go on to their underlying adjuvant therapy. What we found is that all patients underwent IRE safely. First dose of nivolumab was administered in all 10 patients at day 3 to day 5, with 8 out of the 10 patients getting nivolumab throughout the entire 6 weeks. 2 of them did not because they were not able to drive back because of just fatigue. They said, I'm just too tired to come back for our 6-week appointment, not because of inpatient adverse events or hematologic events. Only one immuno-related adverse event occurred, and this was in the patient who had all 4 doses. Approximately 2 weeks later, did develop some colitis that resolved essentially with non-operative management and really no management at all, since he had a little bit of abdominal pain, went to a local ER. They diagnosed him with colitis and then sent him home. And we saw him 2 weeks later and it had already resolved. We did see preliminarily a significant reduction in C19-9 levels, as well as an improved disease-free survival. So we were very, very intrigued by this and obviously very hopeful for this. Unfortunately, this data came out with 5 or 6 other negative immuno-oncology studies, and so Bristol Myers walked away from it. They had nothing; they didn't want anything to do with it. They did not feel that pancreatic cancer was an area for them to focus on, and so did not want to move on to the planned phase 2 study, which was going to be a 40-patient study with 12 months of therapy. Try as I might to try and get any immuno-oncology company to bite into this, whether it be for nivolumab or Keytruda or atezolizumab. So far, they have still been reluctant, and we have not been able to re-engage that arm of our treatment, which has been a big sort of, I would say, ongoing challenge for us. Now, the other aspect of that, though, is also the pushback from the patients. And the patients, as well as some physicians, were asking, well, you start me on this immunotherapy, and you want me to take it for 12 months. Well, how do you know it's working? How do I know that I'm getting any type of immunologic benefit, right? How can you measure that aspect? And that was an unmet need. We didn't know. There are clearly some toxicities with immuno-oncology and clearly immuno-oncology therapies. And clearly we need to have a better marker of response. And that's predominantly going to be a serologic marker. What we're trying to assess is, could we potentially test patients' both peripheral immunity, and is there a sweet spot where that peripheral immunity then turns into a central immunity, which is another term called trained immunity. And this was an initial study that, again, Connor did for us and looked at CD4 memory cells, because we wanted to begin to see where was that sweet spot. How much time did we have to elicit and initiate, hopefully, that transient peripheral immunity? And if we were able to continue that going, could we turn that into a central or that type of trained immunity? And ultimately, what we identified in these patients, in approximately 60 patients that we studied, is that day 90 is really our peak. When patients get IRE and then nothing else, no immunotherapy, we see that type of transient CD4 memory cells that will elicit to about 90 days. And then after 90 days, we get that either fatigue or we get that wear off. And we don't see it anymore from that aspect, from this study. And from that, we clearly demonstrated that IRE and Nivo was safe. 80% completion rate in just 10 patients, with 2 obviously not getting from a travel aspect. So we felt we had all of the data to move forward. But as I said before, we still have not gotten funding. And funding for immuno-oncology therapies are hard. Each individual dose of Keytruda or nivolumab or atezolizumab is about $15,000 each. And so if you're implying about trying to give a patient close to 20 to 24 doses in a 12-month period of time, you can see where that expense starts to add up, that no one wants to potentially eat that. And so trying to get free drug or trying to get administered drug of this has still been an ongoing challenge for us. Now, again, that continued question remains about the permanency of that aspect. And this is that type of effect that we saw, as I mentioned before, where we saw that initial transient CD4 memory aspect at 90 days. We needed to validate that. And so Connor was very, very instrumental in working with Jun Yan, who has been obviously a huge collaborator with us in the division of immuno-oncology. He has a very high flow, what is called a CyTOF machine, which allows us to run nearly 36 markers at one time. He has been very gracious to allow us to use this machine for our serologic evaluation so that we can evaluate what type of marker effect occurred. And so these were a larger subset of patients, again, that were preoperatively, postoperatively, all the way out to 12 months. And we continue to collect blood on these patients to try and evaluate that type of effect. All of these patients have been followed long-term because we wanted to see, are there potentially some immunologic markers that potentially would correlate to recurrence of cancer, both local recurrence as well as distant recurrence. And so Connor evaluated these patients. We did have 19 that recurred at a disease-free interval at 22 months. And what he ultimately found, again, CA19-9 is still predictive in the approximately 60 to 70% of patients who express a CA19-9 level. But the other part he demonstrated is that there are potentially immunologic markers at day 90, meaning that day 90 effect that will then predict what will occur 6 to 12 months later in a patient's underlying malignancy. And what he found again is that CD4 memory cells in patients who did not recur had a near twofold increase to patients who did recur. This also was in regards to CD3 lymphocytes, as well as mucosal-associated invariant T cells. So we do see that there is a potential immunologic marker where a patient may get a benefit and then start to then transiently come down, or may not get a benefit, meaning we may augment them, we may do an IRE on them, but because of their underlying bone marrow, or because of their underlying age, or because of their underlying comorbidities, they don't get any vaccine effect. That's why you've seen some people who have gotten 1 or 2 COVID vaccines and have been fine. You've had other probably people who have had 4 or 5 of them and have still gotten COVID. That is part of our genetic makeup, and that is something that we need to begin to be able to test to assess what is a patient's immunologic strength, or what I classically call it is what is their immunologic fitness and how long it would last. And so this gives us a marker as to what we can do to test patients as they continue on their immuno-oncology therapy, depending on what that would be. We ultimately do see that central memory cells do predict recurrence. Early natural killer cells also will have a significant effect on predicting a patient's recurrence. Why this is important for us is that what we're also hopeful to do is to be able to do IRE in a minimally invasive approach, be able to do it laparoscopically with a single insertion probe. And that concept would be is that ultimately a patient would potentially come back once every 8 or 9 months, get a single percutaneous electroporation, which would then augment their antigen presenting cells and make this type of response last longer, is a concept that we hope to get to in the future. We are not there yet, but that's obviously one of our areas. Now, what are some of the other agents that we can use? Clearly, with our rejection multiple times from pharma, I had to look at other areas. And so another area of focus that we've looked at is actual intratumoral injections of an immune modulation agent. I spoke about this when I was talking about HCC, because we do have SBIR funding in hepatocellular cancer and just got our phase 2 funding for a $1 million extension of that in hepatocellular cancer. But we wanted to look at this in pancreatic cancer in that same concept. If we do IRE and then immediately after IRE inject IP001, which ultimately is the trade name for a specific variant of a chitosan, could we elicit that type of immune modulation or that type of vaccine effect? It has been around for a while. It has been known to induce a systemic T cell response. And there has been a wealth of data looking at multiple different cell types, looking that we do get that type of activation T cell response when you combine a thermal-based ablation with IP001. The most common thermal ablation has been laser ablation. We have opened up a IDE study looking at radiofrequency ablation. And the only reason they're having to use radiofrequency, it's a little bit slower of a heating aspect. But no one has actually looked at this from an IRE or an electroporation type of aspect. And could we get that type of synergistic effect? Data around pancreatic cancer has definitely been favorable with you looking at this type of chitosan in regards to a significant increase in interferon gamma, TNF alpha, as well as interleukin 12 in pancreatic cancers, published back as far as 5 years. More importantly, there has also been an off-target effect, or what they call a double flank. And again, for the students and residents, that means is that basically investigators put tumors in both the right and left flank. You only treat the right flank with the ablation and the IP001 injection, and then you just see what happens to the left side. It's basically a metastatic model. if we treat the primary tumor, what happens to the micrometastatic or macrometastatic disease? And that really was the main aspect of us. I don't stand here and say that obviously a vast majority of pancreatic cancer is localized. I understand that. There is clearly nearly 80% of patients at the time of diagnosis have micrometastatic disease that we cannot see or clearly they're high risk for. And so that was the concept that we wanted to do. Could we see that type of synergistic benefit of doing IRE in a primary tumor, injecting IP001? Would it affect an off-target metastasis that was also placed within the liver? And so what we created was an oligometastatic model using PAN02 in small animals, mice, and then did a very others untreated IRE alone, IRE with IP001, as well as IRE with anti-PD-L1 in administration to see if there were going to be any type of effects in regards to the off-target tumor. We would treat the primary tumor with therapeutic effect and then leave and then treat the oligometastatic disease and see what happened. So initially what we started out with is the initial model was to treat IRE with IRE and IP001 and then follow this oligometastatic lesion. And ultimately what we did see is that there is significant synergy with IP001 as well as with an anti-PD-L1, which I've already presented to you. We've already have that. We just can't obviously expand on that. But what we have seen is that IP001 and IRE administration is inducing that type of effect so that we are getting significant amount of reduction in overall tumor size, as well as significant effects within the immunologic cells in the off-target tumor. What we saw is a decrease in T helper cells, but an increasing in circulating tumor serologically when we harvested the animals at 3 months post. We saw a significant amount of cytotoxic T lymphocytes in the untreated oligometastatic lesion, and then also found significant intratumoral effects for that in the animals that were treated with IRE and IP001. So there clearly is also a synergistic aspect of this. And with this preliminary data, we do have an R01 that's been resubmitted in collaboration with this company called Immunophotonics to see if we can expand on both the animal work, but then also move into human trials like they're already doing in some of the other malignancies. Now, what about oral therapies? And I'll finish in the last 10 minutes with some things that you've already heard that obviously Dr. Junyan has already talked about us this calendar year. And then obviously Matt Wieste has gotten his PhD with him specifically on that. In the idea of oral immunotherapies. We've talked about IV and systemic activity. It sounds great, but if you can't get it and it's too expensive, it doesn't make it adoptable. Intratumoral ones are we as surgeons we could use, but if we're only administering it once, the key question again is how long is it lasting? Clearly, a single irreversible electroporation with an injection of IP001, we can't say is going to last for years. And so there is obviously a potential goal of where oral immunoactivation therapies could come into play. And that's where beta-glucan has obviously been a huge area of interest, both in our lab as well as the Division of Immuno-Oncology, specifically looking at its immune modulation and immune activation. It is a orally food supplement. You can buy it on Amazon. It's not hard to get. So its cost meets our criteria of very easy to get. The aspect of it is clearly its activation in regards to how is it truly working? And more importantly, if you give it orally, the biggest question for the students in residence you should always have is what is the bioavailability? Just because you give some orally, does it go anywhere? Well, actually, it does. And Annie Geller, one of our medical students who is doing her residency, and I forgot where she went to, demonstrated when she was working in June's lab that there is a significant amount of beta-glucan tracking directly to the pancreas. As of yet, we still don't know why, but it is clearly a significant amount of target. Now, this beta-glucan was administered intraperitoneally, which is how she found it. But clearly, this difference caused a great deal of enthusiasm. More importantly, we also see that beta-glucan does indeed train. And when I mean train, I mean potentially taking a animal that has potential transient peripheral immunity and turning that into more permanent central immunity. That is the concept of training and that type of durability. And we do see that beta-glucan induces that in myeloid cells in the murine pancreatic model. It also clearly does have some anti-tumor function. So it clearly was something that they tripped on, but obviously saw a great deal of interest with. And thankfully, June then obviously brought that to my attention to see if we would be interested in collaborating. So this type of activity and this type of interest was of utmost use to us. And so that's why we then expanded our phase 2 study. And we've been doing this now for the last 4 years, looking at using oral beta-glucan. So instead of a patient getting nivolumab at day 5 to day 7 after IRE, they're actually getting beta-glucan twice a day and taking that twice a day out to 12 months as a form of adjuvant immune modulation therapy. We now have over 25 patients that we have treated with significant amount of safety and tolerance to the oral beta-glucan. In addition to that, there's a subset of patients who have gotten their oral beta-glucan while also getting their adjuvant chemotherapy. And again, we've not seen any type of enhanced toxicity. So the overall tolerance and access to the drug or food supplement is really a better term, has been significantly impactful. I'd then like to finish, obviously, if any of you all were at the Brown Cancer Center retreat last Friday, and I definitely want to obviously give a plug to our current PGY4 resident, Matt Wieste, who obviously got his dissertation on this. He did an integral amount of work in looking at this combination of beta-glucan and IRE in a pancreatic tumor model, truly active looking at this from an aspect of, if we do an ablation and then initiate beta-glucan, are we going to see any type of benefit? Just because we can maybe give a food supplement, we definitely don't want to give the patients false hope and say, hey, take this and let's just see what happens. We clearly need to validate this. And Matt's published paper, which just came out early part of the year, demonstrated a significant amount of activity, both in tumor weight and maximum tumor size, but then most importantly, in that altering of a peripheral immune landscape. Now, part of his paper just looked at 3 patients at baseline in 3 months to see, are we seeing that type of peripheral immunity? Are we seeing that type of hopeful, that initial training of patients who are taking this? And we do see a significant amount of change demonstrating here, both in regards to their T regulatory cells, significantly decreased in all patients who were after IRE and beta-glucan at 3 months, as well as an increase in TNF-alpha in most of the patients. Interestingly, this one patient, which Matt really and I dug deep into, is a patient who had a significant amount of chemotherapy prior to IRE and then was restarted on chemotherapy fairly aggressively by their medical oncologist. And so most likely had just chronic bone marrow suppression is probably what we saw. But clearly we saw a significant amount of activity in the other 4, which makes us quite, I think, hopeful for this. We now have those 25 samples that we are now currently going to run, because our biggest question and the biggest criticism of this is, and how long does it last, right? 3 months is great, but no one wants to do something just for 3 months benefit. And so that's our key question is, can I prove to patients, because now a lot of them are asking, I'm at 12 months, should I keep going? We don't know yet. So that's why we're running these samples now in the next month or so that we can see, are we seeing this type of TNF-alpha? There is a subset of patients who are 2, 3, and 4 years out from their IRE that are still completely disease-free. And so they are part of this study. So we're hoping we're going to be able to see what is that immunologic predictor of outcome so that we can identify which patients are getting a benefit of oral beta-glucan and why, and then figuring out where beta-glucan potentially fits into the other augmentation type of techniques, that being intratumoral, but most likely, obviously, in the combination with a PD-1 or a PD-L1 inhibition. As I've mentioned before, this is our ultimate goal, right? Our holy grail in pancreatic cancer is, can we elicit central trained immunity so that when a patient sees any type of regrowth of micrometastatic disease, their immune system will identify it and will immediately eradicate it. We're not there yet. We've been able to obviously test and evaluate peripheral trained immunity for short interval time, but the longer interval time is really going to be, I think, our most important thing that we're focusing on now. So in summary, I hope you all have some enthusiasm and optimism that combination of immunotherapies to generate this type of anti-tumor effect is critical to pancreatic ductal adenocarcinoma. Systemic cytotoxic chemotherapy is still the backbone of our treatment. And ultimately, they may stay the backbone in the first 2 to 3 months of patients. However, most patients can only tolerate a maximum of 4 to 6 months of therapy. And that's our big question, is what do we do after? And so if we have an ability to minimally invasively augment and overcome the tumor immunosuppression, and then augment a patient's immunology to then allow them to have that type of trained immunity, clearly that type of benefit, I think, makes sense. Looking into additional novel immune and disruptive therapies that are potentially now need to be minimally invasive. Right? I think we've been doing open irreversible electroporation now for 15 years. We've not really evolved, and that is a critical piece that we need to move forward for. Is can we do this minimally invasively, either laparoscopically or robotically? So in conclusion, clinical trials for pancreatic adenocarcinoma have been horrible. There's been very little enthusiasm from that. The main reason is that immunosuppressive mechanism. There is no way that we can deliver a high enough dose or any high enough tumor disruptive dose to that tumor microenvironment and that significant amount of desmoplastic fibrosis. Therapies in combination, as I've gone through, is ablative treatments clearly do work synergistically. I think further working on optimal timing, as I've mentioned before, dosages of therapies, whether oral or systemic or intratumoral, is obviously going to be our next primary challenge. And then ultimately, the aim is to obviously better characterize these patients, assess their underlying immunologic fitness, maybe at the time of treatment or at the time they finish their cytotoxic chemotherapy, so that we can assess what type of immunologic fitness or immunologic prehab they need. Because there's no reason just to shotgun and throw nivolumab, Keytruda, all of those at these patients if we only think 50% of them potentially could respond. If we can potentially phenotype these patients and saying, no, you need another 2 months of something else before your bone marrow recovers and you're going to be active, I think it'll be critical to minimize toxicity of IO-based treatment, but then maximize the benefits in this devastating disease. Thank you all for your time and attention.
Thank you, Dr. Martin. Really thought-provoking talk, and showed you the power of collaboration of our surgeons and surgeon scientists and laboratory scientists and a multidisciplinary team in trying to make progress in translational research. I'll remind everybody that melanoma, a decade ago, was a disease that was treated by surgery and surgery only because it was the only treatment that actually worked, and all of our therapies were futile, and it was thought to be a kind of cancer that was forever going to be resistant to systemic therapy. Now, of course, with immunotherapy, revolutionizing treatment of melanoma, where we have 55% of patients with stage 4 disease who used to die within 8 months on average. Now 55% of them are alive at 5 years in stage 4. Pancreatic cancer is in the same boat that melanoma was in, where although systemic chemotherapy has improved dramatically, it has extended survival, is thought to be resistant to immunotherapy. So, Dr. Martin, I'll ask you about the high-profile paper from MD Anderson a year ago or so. It showed triple immunotherapy combination, very, very promising in animal models using LAG3 and CXCL2 and another that really seemed to break the ice in terms of opening up possibilities. What are the implications for your work in trying to extend what you've done already?
Yeah, I think that's exactly right. I mean, we've seen a number of, I would say, initial benefits in animal models and phase 1 studies with targeted therapies. Our thoughts are we would love to investigate, each in sets of 10 across the United States would be a great aspect. Our biggest challenges we have seen is it just, I guess, from an educational standpoint, all of pharma that is out there, and for all the companies that make, their chief medical officers are all medical oncologists, which I have come to realize, and this is not a detriment, it's just the way education works. The last time a medical oncologist was in the operating room was their third year of medical school. So their idea of collaborating or accepting that a surgical, meaning a patient going to sleep, even if it's through a minimally invasive, disruptive therapy needs to be done to make their drug better, has been honestly my biggest heavy lift. Their answer is, no, that's too much. We just need to now get a quadruplet. There's got to be an additional therapy out there. So I'm trying to work with that. But again, Young Hong has worked very well with CXL9 and 10s as an epigenetic type of therapy that he's been working with his lab. He's almost ready for us to hopefully begin to collaborate to use that in the pancreatic cancer model too. So I think there are definitely markers out there. We're just trying to, the biggest heavy lift is to hopefully get the pharma to unlearn that surgical activation could be a benefit for them.
So follow-up question, you referenced radiation therapy as a possible mechanism for doing the same thing, causing enough cellular disruption to cause antigen release and immune response, a window of opportunity, which is obviously a little less invasive than an IRE. What are the data to suggest whether radiation therapy can do the same thing or do it as well as IRE?
So there's two publications out of the AMC, or the Amsterdam Medical College, that have looked at SABR, or stereotactic body radiation therapy, as that. What they're seeing is that they have seen that there is some upregulation, but it's about a third intense. So they're not getting as much. Now, part of that may have been dosage. They weren't comfortable pushing it that hard. When I've talked to Chris Crane, who's one of the prominent radiation oncologists at Memorial Sloan Kettering, where he's giving like 7,000 and 8,000 centigrade, which is a really, really high dose. They are seeing a slightly increase in that. But again, the biggest issue they've had with radiation is they can't give a large enough dose that's safe that induces a similar amount of immunologic effect.
Other questions, comments? In the back?
Good morning, what not doing a different way to deliver diary rather than microscopy, or if you use it up for ultrasound or some other forms to try to disrupt that may be a little safer, with a little less invasive?
Totally agree. And that is one company that is actually is looking at this, is actually in cardiac ablation, because you can also use this in a cardiac ablation device. The biggest challenge that we've had from an engineering standpoint to deliver IRE, you need to have ability to deliver close to 2,500 to 3,000 volts. And that's between a positive and negative electrode. Now, you can do it on a single probe because the tip could be positive, the back could be negative. The biggest engineering trouble they've had with that amount of voltage is diameter. And so we're still stuck at about a 14 gauge probe, which obviously won't go through anything endoscopically, and I wouldn't put it into the pancreas either. So they've had a really hard time getting from a 14 gauge up to a 19 gauge. It's the desire they want. They just haven't found out the engineering aspect of that. But it's a concept that is definitely needed and could be much better. Yeah.
Outstanding.
There's some data to suggest that animal models also might be immunogenic. Wonder thoughts about that.
Yeah, I think it's, again, a big concept that we've been trying to look at is regards to is the distribution. I mean, as you know, from a hypervascular standpoint, is from a nanoparticle standpoint, could we give it intravascularly is the one challenge. And I've been anxiously looking at sort of the Renovo RX, which is a trial we kind of looked at, which is a balloon catheter that sort of isolates the gastroduodenal artery, or one of the feeding arteries in the pancreas, and that potentially could give high dose therapy to that. The problem is the distribution that we're still struggling with. I think the other way of nanoparticles, if they can put it into type of an emulsion or some type of desmoplastic disruptor for a period of time, endoscopic ultrasound would be the perfect aspect. Every 3 months, you just get an EUS, get your nanoparticle injection, and then continue on with your systemic therapy. That would be, I think, obviously the holy grail potentially in the treatment of this disease.
That's right.
Great progress. You see this sort of fewer immunosuppressive microfiring. Metastatic, previously, well, it's primary.
Right. It ultimately do see it in the metastatic lesion as well. And again, I've taken that, both from some, anecdotal clinical aspects. Now, we don't believe they're as cold. So I guess there's a descriptor in that. The pancreatic tumor, as you know, just well as I do, is obviously probably, 10 out of 10. What we're finding with the metastatic lesions is they're still about 5 out of 10. There's still an immunosuppressive aspect of that makes, because if there wasn't, we would expect that immunotherapy would work really well in metastatic lesions, and people would be publishing, distant disease-free survival and going, oh, the primary tumor's growing, but we eradicated all the metastatic disease. So we're still seeing that with the metastatic lesions as well.
Consider sort of the IRE and that's like you used to do. So like the
Yes. Right.
Release the end app.
Yes. Without a doubt, definitely is. And that's that R01 that we have hopefully pending is going to go after that type of metastatic lesion, which is that continuation of that phase 2 trial that Immunophotonics has put on, but they have, kind of weird diseases with it, colorectal, sarcoma, and lung, and we have to use RFA. We have it open here, but we haven't enrolled anybody because we haven't found the right person. But this would be that perfect segue into that we could potentially amend on that IDE and FDA approval.
All right, we're going to have to stop there. Thank Dr. Martin for an outstanding.
Thank you.
5 minute break. You all right, Billy?